chair of the psychology department and also presiding officer of the College of Arts and Sciences, and I would like to welcome everybody tonight to the College of Arts and Sciences Distinguished Lecture. This lecture is an event with a long tradition. You have your program and you can see all of the other previous distinguished lectures that we've had over the years. We're very lucky this evening to have Professor Gary Harper of DePaul University, who will be delivering tonight's distinguished lecture. I would like to introduce him and say a few words about him and his work, and then I will be presenting him with this plaque as the Arts and Sciences Distinguished Lecturer for 2008. Professor Harper was born in St. Louis. He attended St. Louis University as an undergraduate. He attended graduate school at Purdue University in West Lafayette, Indiana. And we found out today, by the way, at Purdue University, one of his professors was our own Craig Hill, who taught at Purdue for a couple of years at the time that Professor Harper was a graduate student. And so he taught him personality psychology, which I assume some of you have also taken from Dr. Hill at the undergraduate level. Professor Harper earned his Master of Science and his Ph.D. in clinical psychology at Purdue with a focus in child clinical psychology and a specialty in pediatric psychology. After that, he did a clinical internship at the University of California in Los Angeles, and at the same time was accepted into the traineeship in HIV Prevention studies. He also earned a Master in Public Health and Epidemiology from the University of California in Berkeley around the time that he was doing his internship or shortly thereafter, and completed a part-time clinical fellowship at the Youth Guidance Center Psychiatric Clinic in San Francisco. In 1996, he came to Chicago and became an assistant professor in the Department of Psychology at DePaul University, where he remains today, having been promoted to associate professor and full professor over the years. He is also an affiliated faculty member in the Women and Gender Studies program and directs the Master of Public Health program, and is co-director of the Community Psychology program at the Center for Community and Organizational Development at DePaul. Professor Harper has received many awards for his work. I want to say a little bit about his work in a moment, but in your program it names several of the awards that he has won or earned over the years, and has had a great deal of recognition for his work. Throughout his career, he's been particularly interested in using psychological theory and research to promote the health needs of young people, but particularly young people who experience degrees of oppression and marginalization. He would like to use his skills and position as a psychologist to promote the social justice needs of young people who are marginalized. He has done work in a variety of different areas, but particularly been dedicated to addressing the HIV prevention and health promotion needs of adolescents who are marginalized in a variety of ways. That includes homeless youth, urban African American and Latino youth, gay, bisexual, and questioning youth, and also primary school children in Kenya. He has stated that social justice values have played a major role in his career, and he thinks that psychologists have a particularly wonderful opportunity to use their skills and abilities to give voice to individuals and communities who are silenced by oppression. And so that has been one of the guiding features of his work in psychology. So tonight we will be hearing about his title talk, which is Developing Culturally and Developmentally Appropriate HIV Interventions for Youth. So I would like you to join me in welcoming Professor Gary Harper. And you're in for a wonderful lecture this evening.
Thank you very much for that very kind introduction. And thank you all for coming tonight. I know it's Thursday night in Fort Wayne, and there's probably other things to do. So I appreciate you all coming here. I feel kind of strange being on this big stage. I was telling some folks I didn't know if I should do a dance in the beginning of the talk, or I don't know what the regular protocol is, but I'll just stick with the traditional talk, and we'll save the dance for later. So what I'm going to be talking about today or tonight is a series of studies and projects that I've been working on with a number of different collaborators. One thing is that I definitely don't do this work alone. And I feel uncomfortable at times getting recognition for it because it's really all the work I do is collaborative. So it's collaborative with other people from different disciplines and backgrounds. It's collaborative with youth. I involve youth in all phases of our projects, no matter what we're doing, whether it be in Kenya or here in the United States. So working with undergrads, grad students, everyone. So it really is a collaborative process. So I want to make sure that you recognize that this isn't just one person. And I do, and when we talk about the different studies, I'll recognize and give voice to some of those folks. And I think that it is important that we, in various disciplines, make sure that we use whatever it is that we're doing to make a difference in the world. I think that especially for students, sometimes you sit there and you hear all these theories, and you hear this study and that study, and you're like, okay, well, what do you do with that? And hopefully tonight you'll get an idea of what you can do with that, because it's one thing to do the research and learn the theories, which are all very important, but it's another thing then to take action and to really have an active voice in your society. So hopefully I'll be able to demonstrate that. Just giving credit to some of the funding I've gotten. I'm going to be talking about studies that I've done over about the past 13, 14 years, and have been very lucky to get a variety of different sources to help fund this. And a lot of times these are studies that we piece together, a little bit of funding here, a little bit of funding there. So it's not all big $1 million grants from the National Institutes of Health. It's been a variety of different projects. So I'm going to start off with a little activity, all right? So you didn't think you were going to have to work, right? You thought you could just sit there and passively listen. Not the case. All right. So in object number 1, if you have a piece of paper, write it down. If you don't, try and keep it in your head. Write down what you see in that box. Don't talk to anyone. Don't cheat. Don't talk to your neighbors. Pretty easy, all right? Anyone do it? I'm seeing if anyone's actually doing it. All right. Okay. Now here's box number 2. What do you see in box number 2? And in box number 3. All right. So someone tell me, what did you see in box number 1? A ring. Anyone see anything else? Frisbee. Okay. A Cheerio. Okay. Anyone else? Okay, we had some variability. What about box number 2? What do you see? Light bulb. So I see general consensus that that's a light bulb. Anyone see anything else? Okay. What about box number 3? What's there? What? A push button. Okay. Anything else? Pardon? An emerald. Okay. What else? Anyone else? A green square, okay. The obvious is always a good answer. So if all else fails, just say what you see. All right, there's no trick. All right, the reason why I do this is to really point out the fact that we don't always have shared meaning about what we see and what we experience and how we view things. And when we develop prevention programs, if we only come from one perspective, we're going to be missing a lot of people out there. And so I think a lot of times when prevention programs or other interventions are developed, and we don't take the time to learn from the people who are going to be experiencing it, we may have one perspective. So we may see a ring there, but you see a Cheerio. And that probably has to do with your background or your current life circumstances. And so we have to really think about the context through which people are understanding the material that we're talking about, the lens through which they're viewing it. And that's a big part of what we do. Just a real quick background on adolescent development, since all the projects I'm going to be talking about are about adolescents. Adolescents are going through a stage of development. They're developing in different areas. So biologically, cognitively, socially, in terms of their identity, intimacy, autonomy, and sexuality. So there's a lot going on during this time period. So in developing different programs, we have to recognize that these are developing human beings that are developing different skills, different abilities. They're dealing with different stressors. And so even though I may be focused on HIV prevention, I still have to keep in mind that the adolescents I'm working with are dealing with social issues. They may be dealing with identity issues in different ways. So I always keep that developmental context. a lot of my work is guided by Bronfenbrenner's ecological systems theory of human development, which is a belief that we have the individual there at the middle, but the individual is influenced by different groups within which they function. So we have the school system, home, workplace, church, peer group, and then as you go out, it talks about different interactions of groups in the mesosystem. The exosystem, you see larger groups, mass media, religious hierarchy. Macrosystem, we're talking about dominant beliefs and ideologies. And then on the outside is the chronosystem. This is the belief that these things are constantly in motion, they're constantly changing. And so this is a framework that the folks that I work with and I have really used in developing a lot of these programs. Some things to think about in developing HIV prevention programs. One, as I mentioned, is developmental factors. We also have to think about linguistic and language factors. Now, oftentimes when we talk about language or linguistic issues, people are talking about, is it in Spanish, is it in English, is it in Swahili? But we're also talking about youth language. So youth language may be very different than what older folks use or what people from different age groups use. So we have to keep in mind that if we don't have our programs in the language that people don't understand, they're not going to be getting the messages that we want them to get. Just like in that beginning slide, I may think that I'm showing you a ring, but you're seeing a Cheerio. We don't have shared meaning. We don't have shared understanding because we may be using different languages. Social peers are very important during adolescence. As you all well know, adolescents become very important in terms of socializing forces, teaching us new things, learning. We try out new behaviors around our peers. So we have to think about the role of peers when we're talking about HIV. Community and environmental factors. We all live in some type of neighborhood or city or physical environment. And if I'm doing an intervention in a low-income urban environment with lots of violence, that's going to be very different than if I'm doing it in a rural community with not many resources and not many neighbors. Culture is another. So when I talk about culture, I think a lot of times people automatically go to ethnic and racial issues. That's important, and it's something that we consider, but there's other forms of culture. There is a youth culture. With youth culture can come language, symbols, all the different factors that we talk about and talking about ethnic culture we may have with youth culture. And then I have LGBTQQ, lesbian, gay, bisexual, transgender, queer questioning, a whole variety of different factors related to sexual orientation and gender identity, and there's different cultures that go along with that as well. And then societal issues. Not all people are treated the same in society. You know, no matter how much we want to pretend like everyone's equal and it's all wonderful and we all live under a great rainbow of happiness, people experience oppression every single day just because of the color of their skin, just because of having a same-gender partner, just because of having a disability. So in doing interventions, we do have to think about the fact that different people are going to experience different degrees of oppression and marginalization. All right, so I always like to try and make things as kind of easy to remember and digestible as possible, because a lot of the work that I do, as Elaine said, I try and help translate into social action and social change. So I work a lot in community-based organizations to take what we learn from research and to put it into community. So I like acronyms. All my grad students tease me all the time because whenever we're doing a new study, I have to come up with a new acronym for the name. And I also like to have short little ways to remember it. So these are the 5 M's of adolescent HIV prevention. So one is meaning. You have to have a prevention program that's going to have meaning. If you're having young people engage in some activity that they don't really have any connection to and it doesn't really mean anything to them, they may come in and do it because they have to for credit or they're getting paid, but they're not going to continue to be engaged. The next is motivation. There's got to be some kind of motivation. It can't all be just external. There's got to be some internal motivation behind why young people are wanting to change. Methods. We have to work with multiple methods when we develop interventions. We can't just talk to people or talk at people, which happens a lot, and say, use a condom, talk to your partner about sex, don't have sex. That's not going to do anything. That's going to go in one ear and out the next. So we have to think about different interactive methods. Money. Now, money means we have to you can look at it two ways. One, we have to put money into programs. We, unfortunately, we're in a state, or in the government nowadays, where a very small percent of the nation's budget goes into prevention. If we look at the national amount of money at the national level that goes into health, and then you look at how much actually goes into prevention, it's minuscule. I was just teaching a class the other night on Intro to Public Health that if we look at the federal health budget, about 1.7% goes into public health prevention, which is, in my eye, is a tragedy. Because the thing is if we can prevent dysfunction, we can prevent disorders and health conditions, we can do, in the end, it saves a lot of money. And then the last, and this was kind of lame, merriment. I know it's kind of an old word there, or make me laugh. It's got to be fun. You know, if I'm doing an intervention or working with intervention and it's boring and I'm just kind of going through the motions, the people I'm working with are going to notice that. If something's not fun, then it's going to be very hard to get people to keep coming back for the interventions. All right, so let's jump into a couple of programs. This is a program that I've been working with an agency called Project Vita. It's a nonprofit agency on the southwest side of Chicago in a community called Little Village. Little Village is about 85% Mexican and Mexican American. It is an agency that's been around for about 15 years doing frontline HIV prevention work. I've worked with them since about 97. And those are some of my collaborators, both people who work at the agency and then students who have worked with me. One thing that we did in starting to work with this agency, they had a program, an HIV prevention program for Mexican American female adolescents. But it wasn't working very well. They had just started. They weren't getting many people to come. So we partnered with them to do some evaluation work to improve the program to try and get more young women involved. So what we did is we used a narrative ethnography approach. So we went in to learn about the people, about the community, about the young women. There's been some work by a community psychologist by the name of Julian Rappaport, who's written a lot about narrative ethnography. He talks about needing to both look at stories, which are personal stories of individuals, but then also looking at narratives. And these are shared or common stories shared in communities. It can be affiliative communities, so communities of being from the same group, or it could be physical communities, or it could be ethnic communities or gender communities as well. So some of the things we did is looked at what are the dominant cultural narratives. These were all Mexican American or Mexican young women, so we needed to learn about that. We needed to learn about the community narrative. Going back to my earlier slide, people live in communities. So if I'm trying to change someone's sexual behavior, that sexual behavior is taking place in the context of a community. If I ignore what that community is like and what the stressors are, then I may try and get you to change your behavior, but as soon as you leave my intervention and you go back to your community, you're right back where you started from. And then personal stories of the staff, the clients, and the community members. So some of the methodologies that we use, some of the things that we did individual in-depth interviews, and through this we learned a lot about what the dating and sexual scripts were for young women. So what are the messages that they were getting about sexuality? What were the things that were handed down to them from their families, from the culture, about what a good Mexican girl is supposed to do? And that's kind of their language, their quotes. We also looked at what were the unique stressors. I'm not a 15-year-old Mexican-American female living in Little Village, so I don't know what those stories are. So we had them talk about some of the unique stressors. We also did focus groups with young women who had been through the initial program to try and learn from them what they liked, what they didn't like, what they would want to change. We also gave them a role in this process. So they knew that from the beginning that they were going to help shape the program so that they could take ownership for it. We were there to help build it, but then they're there to continue to deliver it. It's not my program, it's their program. I see myself often as a facilitator or a capacity builder, not as the person who's going to actually implement it. We did non-participant observations, and this is where we had undergraduate women, young women who were Mexican-American young women who became part of the group. Well, they were in the group, but they weren't actually part of the group. That's why they weren't actually participating, but they observed what happened in the group, and they were able to make observations that we couldn't get from recording. So if you record something, you hear what goes on, but you don't see what goes on. So they did all kinds of ecological assessments of what was happening in the physical space and in the room. We also looked at written text, rituals. There's a lot of rituals that take place in communities. So there's certain rituals, like, for instance, in this community, there's a woman, Senora Maria, who made delicious homemade food. And she would come by every day at 10 a.m. and again at 6 p.m. with her food. Now, if you had a meeting, you knew that at 10 a.m. it had to stop, and you had to go get food because that was part of the ritual. It was interesting. We were there one time, and the people from the Centers for Disease Control were there because we were up for a grant. And they were there, and it was 10 o'clock, and the entire office got up and left. And the people from the CDC are sitting there like, what happened? Did we say something? Did we do something? Like, no, it's 10 o'clock. And, I was just so used to it that I got up too. And so we had to explain to them that that's part of the community ritual. We also had to look at physical spaces and structures. When you're thinking about developing programs, you have to be able to do things that are going to work within the physical confines of the community. Some of the things that came out of this, some of the themes, there was a need for a lot of sexual and reproductive awareness and health. The issue of sexual pleasure. A lot of prevention programs, HIV prevention programs, take pleasure out of the equation. Why do people have sex? It feels good, right? You don't have sex because your mom said you have to do that, or because you're getting credit for it. You do it because it feels good, right? Come on, right? You're a really quiet group. Okay, so maybe you don't in Indiana. But anyway, I haven't lived here in a really long time. But sexual pleasure is something we don't talk about. And especially talking about young women and sexual pleasure makes people very uncomfortable. And especially coming from a Mexican culture, which has a lot of sexual silence, especially for women, that's a huge taboo topic. But what the girls were talking to us about is, we do it because it feels good. We want to do it because we want to experience it. So we have to take that into account. Catholicism and religion. Most of our participants were Catholic. And there's a lot of taboo around condom use, around premarital sex, and other issues. So if we just ignored all that, and then we said do X, Y, and Z, but we didn't pay attention to the fact that when they leave there and their mom gives them the rosary and is telling them they're sinners and they're going to hell for this, or that, we have to deal with that. Pregnancy. A lot of messages for the young women about the sanctity of motherhood and that you're only a woman when you're a mother. It's kind of the double bind where you have to be the virgin and be like the Virgin Mary and be pure, but at the same time, the only way to truly be a woman is to have a child. And so these were very strong messages that they talked about as well. Sexual assertiveness and communication. If you have sexual silence, how do you talk about sex? No one has ever taught you how to talk about sex. No one's ever talked to you about how to say, no, I don't want you to touch me there. No, I don't want you to do that to me. And then gangs. This is a community that has a huge gang issue. And so if we ignore the fact that a lot of these young women are either affiliated with gangs or dating gang members, and if we look at the role of sexuality in gang rituals, especially for female gangs, getting jumped into a female gang, at least in this community, often involves sex. Sometimes it involves having sex with an HIV-positive partner. And it involves a lot of other often sexually laden material. So this is something we had to pay attention to too. So the program is theoretically grounded in the AIDS risk reduction model. This is one of the few theoretical models designed specifically for AIDS prevention programming. It was based on a lot of both social psychological different theories, has elements of social cognitive theories in it and other types of health behavior change theories. We address a range of social, cultural, and relational barriers to HIV, a lot of the things I talked about. The program is delivered by young women from the community. So I can't go in there and deliver it. They're not going to pay attention to me or believe me when I'm talking about sexual pleasure. They're going to get embarrassed and not talk. It's not appropriate for me to be in that space. So it's delivered by young women from the community. These are the different sessions. So we had women's sexual health, pregnancy, HIV transmission, dating, self-esteem, protective barriers, gangs, communication, sexual assault, and sexually transmitted diseases. So some data to show you about what the impact or the influence was of this program. After developing this for about 2 years, we then did a 2-year study using a quasi-experimental design where we had what we called the socioculturally tailored intervention, which was the 9-week intervention called SHEROES. It's the participants chose that, the feminized version of HEROES. So the SHEROES version was that, and then the minimal intervention was a basic HIV education prevention intervention. Our participants, there's the numbers there, 183 in the treatment, 199 in the control or comparison. Participants on average were about 15 years old, lived at home, attended school, were Catholic and bilingual. We looked at repeated measures analysis of variance, both pre-test, post-test, and then at a 2-month follow-up. And we had I don't have the specific numbers, but we had about an 87% retention rate across that. which is pretty good trying to track these young women down over time. We saw statistically significant changes in HIV and STI knowledge, condom attitudes. That was at both post-test and at follow-up. Some of the biggest changes we saw that I think are very important, especially in talking about women's issues and young women's issues, particularly in this community, was around issues of self-esteem and sexual assault. We used a scale by Charlene Mullenhard that's been used in the date rape literature a lot, and looking at sexual assault and aggressiveness. And there's one that's called Leading on Justifies Force. So this is the belief that if a girl leads on a guy and is kind of leading toward wanting to have sex, if she says no, he's justified in forcing her to have sex. At the beginning, they endorsed this at fairly high rates, and so did both the comparison and the intervention. At both post-test and then even at follow-up, the rates for the young women in the intervention were drastically lowered. It was about, their average scores at the beginning were around, I think, 16, 17, and dropped to like 5. It was a pretty huge drop, and it maintained that. The other group actually went up, so they endorsed more of these beliefs over time versus the women that were in the intervention. And then token refusal is the belief that a girl should always say no to sex, but she really wants it. So no means yes. And so a lot of these young women were endorsing that belief in the beginning, but changed over time, whereas those in the intervention, just the traditional intervention, didn't change at all. So again, this shows about, again, thinking about context and thinking about development and culture. If we hadn't paid attention to that and we did a standard HIV prevention program, we may have given them all of the knowledge about condom use and other things, but at the end of the day, if they believe that it's okay for a man to force them to have sex, they're going to have sex, and it's not going to be with a condom. We also saw behavioral changes too, which is hard to find in these types of interventions, especially when we're giving interventions to both. One was a more tailored and more specific. So we saw decreased sexual behavior. So the young women in the intervention, after the intervention, reported abstaining from sex more often. They also reported carrying condoms more often. One of the best predictors for adolescents of whether or not you're going to use a condom is if you have a condom. So, pretty simple. If it's there, you're going to use it. If it's not, if you're in the heat of the moment and you're in a car and you want to have sex, you're not going to say, oh, wait, let's drive to Walgreens and get the condom, and then we'll come back to this really, kind of hot, sexy place in the park. You're not going to do that. You're just going to have sex, and you're going to do it without a condom. If there's a condom in the car, in your purse, in your backpack, wherever, that drastically increases the likelihood that you're going to actually use them. So condom availability, very important. All right, so increased intentions to use condom. This was at the follow-up. So right after both groups increased, so we saw an increase in their intentions to use. In the minimal treatment, that trailed off afterward. In the intensive intervention, it continued to increase. And then increased actual condom use. Directly after the intervention, both groups reported increased condom use, but with the traditional intervention over 2 months, that went back down to below baseline levels. But with the intervention group, it stayed higher. So we were actually able to document through using an intervention that the young women had a real voice in developing, using culturally, developmentally, and contextually important factors, actual changes in behavior. Like that cool little graphic there? It's kind of fun. Yeah, my freshman students taught me how to do graphics on PowerPoint. I'm realizing as I get older, I know less and less about technology, so I have to give credit to my freshman students for that. All right, so this is a project that we've been doing in San Francisco, an area called Bayview Hunters Point, which is geographically, it's in San Francisco, but it's a primarily African-American community that is physically a bit away from the downtown area, and it's a very low-income area with high rates of violence and sexually transmitted infections. Here, we've been working in this community for about, I started working there in 93, so for a while. We did a variety of different qualitative studies in this community first to look at, we were focusing on African-American adolescents and sexuality. Before we even looked at prevention, we wanted to find out about normative behavior around sex. With a lot of groups, people jump right away on looking at risk. We wanted to find out just what are the norms around dating and sexuality and just being a sexually active young person in this community. So we did an array of different individual interviews. We then did a longitudinal study using a random digit dial method for sampling, where we luckily there's one code of numbers, area code, and the first several digits are the same for this geographic community. So we were able to do a random digit dial where you randomly select numbers from that pool, and they're called. And about, surprisingly, 80 to 90% of the homes actually had phones, because that's a concern in some low-income communities, is if you do a random digit dial, but you don't have phones in half the homes, you're not getting a representative sample. But in this, it was actually pretty high. This was quantitative surveys where we followed young people and then their friends. So we brought a young person in who was selected through the random digit dial. We then had them invite in up to 6 friends of their closest friends, and then we we kept them in a longitudinal study over the period of a year. So we studied what we called the seed or index, and then their friends as well. From this, we developed an intervention based on the longitudinal data, focus groups, qualitative interviews, and then just our clinical experience with other interventions. We did a pilot test and a process evaluation. So we did a small test of the intervention, and then we also did process evaluation focus groups with 20 groups of adolescents who had been through the intervention. And then we just wrapped up this past year a randomized community trial where we had different we randomized on the level of community agency, because again, a lot of what I do is working with community agencies to be able to implement this. And so we had a variety of different community agencies that were randomized to either the comparison condition, which was a health and nutrition, or the intervention, which was what we call Project ORE. And ORE is a Yorubian or West African word that means friend. And so that's where the name came from. Some of the things that we saw through our initial work is that close friends play a very strong role in socializing young people about sexuality. We talk to our friends when we're teenagers and when we're older too, about who we want to date, who we're going to have sex with, who we had sex with. And so since that's an important developmental socializing agent, we decided we had to include friends in our intervention. We also found that there were gender differences. I have a paper in Journal of Sex Research where we look at the process for how friends are involved in dating and sexual activity for males and females. And with females, it's much more indirect, and there's much more involvement of friends. And males, it's much quicker. It's basically, hey, do you know this girl? Yeah. Is she single? Yeah. Okay, I'm going to ask her out. Whereas with the young women, it was much more, oh, will you pass this note? And then, oh, what did he say about me? And does he really like me? And okay, well, why don't you ask him if he's going out with anyone? And all this kind of back and forth. So we found that there were real gender differences in terms of the role that the friends play. See, I saw a couple of laughs. You guys did this, right? I mean, some of you did this stuff, all right? All right, so we found, too, that friendships are enduring. It's interesting. If you look at the literature on adolescent friendship networks, a lot of the research, especially at this point where we were doing this in kind of the early 2000s, was done in the Midwestern United States with primarily white samples. And so when we're talking about a community-based sample of African-American youth, we didn't really know kind of how friendship networks were going to hold together, how they were going to last. It was interesting, too, because a lot of the methodology that was done with prior studies were done in high schools, and if you were related to someone, then that person wasn't counted as part of your social network or your friendship network. Well, what we found in these communities is that there were both people who you called your cousin, but they weren't really your cousin, plus there were people who really were your cousin, who was also your best friend. So we changed our definitions, we changed our methodology to be more appropriate to the community and to look at this in a way that was much more culturally appropriate. We also found that drug and alcohol use and sexual behavior clustered. So we had cliques. A clique was a small group of friends that were higher risk cliques and lower risk cliques. And this reflects some of the other literature that shows that if you have friends that are using drugs or smoking or doing other behaviors, you're also more likely to do that yourself. From our focus groups, through the process evaluation, we found that some of the benefits of attending an intervention with friends, one was generally they felt more comfortable. So a lot of interventions, especially like school-based interventions, you do it with whoever's in your class. Or if you do it through a community agency, they just kind of randomly recruit people, and then you're stuck with those people that you get recruited. What we did is we did the intervention where we took a person and we said, okay, we're going to have this intervention with just you and your closest group of friends. So we would have between 3 and 8 young people come together, and the intervention group was your friendship network. And what we found is that they felt more comfortable because they knew each other. You know, if you're sitting around a room with a bunch of people you don't know, and then you're talking about who you had sex with, or you're talking about, questions With males, sometimes, or females, we're talking about just basic human sexuality. So questions about your penis or your vagina or ejaculation or these things. You don't want to talk about that with some stranger, some guy who's in your class that, knows your mother and all this other kind of crap. So you feel more comfortable. Also, the ease in talking and expressing self. You can say things around your friends that you won't say around other people. So we found that the adolescents felt that it was much easier for them to express themselves. Also, they could talk about sensitive information. They could also relate to each other's experiences. So they knew some of them had dated the same people. They'd been through the same experiences. One thing that was really interesting, back to the familiarity one, is that we found that a lot of them were catching each other in lies. So like one person would sit there and say, oh no, I've never had sex before. No, never did. And then I'm like, wait, you just told me last night you were out with so-and-so, and you said you did this, this, and that, and then you were at the clinic yesterday because you knew someone was burning, and so now you're telling me you've never had sex before? So they were like calling each other out all the time in the group. It was hilarious. And then the other one is that time goes faster. So if you're hanging out with your friends for 5 hours, because this intervention is a 5-hour intervention, it goes much quicker than if you're stuck in a room for 5 hours with people you don't know and you don't like. So the intervention incorporated input from experts in ethnic and cultural studies. We work with a woman from UC Berkeley who specialized in African and African American cultures. We also worked with rites of passage issues, community-specific risk data. So instead of just saying this is what HIV looks like in the U.S., this is what it looks like in your neighborhood. This is what's going on in your block. We also emphasized the issue of connectedness and friends protecting friends. So what we did is we used the natural power of friendships in a positive way. A lot of the literature has shown that friends can negatively influence friends, and so they'll talk about the dangers of if you have a friend who smokes or does drugs or whatever, that you're going to do that. So what we tried to do is say, okay, how do we harness that power and use it for something positive? Again, based in the AIDS risk reduction model. We had introduction to rites of passage, HIV facts, assessing risk, commitment to change, condom knowledge, communication negotiation, and workshop closure. Just want to show you one of the activities that we did. This is something that we took from some work in Ghana and in West Africa. So these are Adinkra symbols. And Adinkra symbols are symbols that have different meaning behind them. And what we did is we had the group choose an Adinkra symbol, and it had a little kind of a statement about what that meant that symbolized their friendship group. Because different groups may conceptualize themselves in different ways. And then they were given little stones where they would choose the symbol and the colors, paint it on the stone. This was at the very beginning. It was the initiation ritual, or the beginning ritual. And then talk about how they're all connected through this common symbol, and how they all become part, and how they play into that group that makes them and symbolizes them as a symbol. And you may think, well, what does that have to do with HIV? Well, what that does is it's an activity that helps them to bring them together and to connect on a level where they become more of a group. So you're not just talking about individuals at that point. You're talking about a group. So it's an activity to bring together people into a more cohesive group. I didn't present the data on this. We actually have an article that we just sent the revisions in. What we found in the pilot intervention, we saw positive increases in different levels of behavior change, in terms of attitudes, also in behavior. And then in the randomized clinical trial, or the randomized community trial, what we found is that there were different effects depending on the age. So I was talking about this with Jeannie earlier, that for the younger participants and for the community trial, we just focused on young women. Because in this community, the rates of HIV were just starting to get really much more severe among younger women, and the rates of different STIs, sexually transmitted infections. And what we saw is that there was a different influence at different levels. So for the younger women, they had different influences in terms of getting tested for HIV, up to the older women who reported greater changes in sexual negotiation and condom use and things that took more complicated skills. So as they got older, the changes were most prevalent or most pronounced around areas that took more advanced skills around sexual negotiation. All right, so the next study, I'm going to talk about some of the work we've done with gay and bisexual and questioning young men. I presented some of this earlier today. This all started from doing work with Project Vita, which I talked about earlier, that had a young gay men's program. that we started back in '97. And this was just a very grassroots effort started by young African American and Latino young men who wanted to do something because they saw people in their community getting infected with HIV. So I just started working with them to help them to do some of the initial ethnographic work and really to develop some of the interventions. From this, one thing that I kept seeing over and over and over again and kept hearing these young men talk about through the interventions is this juggling of different identities. So during adolescence, we're developing a lot of our sense of self and our identity. But one thing that it was really striking for me was to see the challenges in juggling being a person of color. So with this, it was mostly African American and Latino. Then also being gay, but then also being a man, because there's so many negative images around gay men that challenge their notion of their masculinity because of all the images of gay men and bisexual men being very, very feminine. So there was a lot of struggle going on with this. So one thing that we did is we did a extensive 2-year study, which again, for people who were here earlier, you already saw this, so I'll kind of go through it a little quickly. At the top, we did community recruitment, where we enrolled 201 adolescents between 14 and 22 at the start of the study, and then as the study went on, they aged up to 15 to 23. We focused on just 3 ethnic groups at first: African American, Latino, and white. We did quantitative surveys, and based on that information, we then wanted to stratify to make sure we had a diverse array of people for our in-depth qualitative interviews. We did our first 19 interviews, stratified across age, ethnicity, and different levels of gay identity. Then what we did is we went back to some young people and said, okay, this is what we're hearing. Is this really what your experience is? We also asked them, too, are there things that we're not asking that are important for us to know? So one thing that came up during this phase is they talked about, we weren't asking any questions about hustling or having sex for money, because a lot of the guys were hustling. And so they thought that we needed to add that. So that was something we added to our qualitative interview. We also went to experts in the field to get their opinion. We then did 41 more interviews. We then fed back this information. We had focus groups with young men who had been in the study, fed it back to them, said, this is what we're hearing, this is how we're seeing it. Is this right? Are we really understanding what you said? We started developing different models and ways of looking at the data, and then we fed it back to them again. Again, we included young people in this whole process to make sure that we weren't sitting off in our offices interpreting in one way. Also, our analysis team was made up of a group of both young men and 2 young women who were members of the community, so gay and bisexual individuals, people from African American backgrounds, Latino backgrounds, and a variety of different kind of socioeconomic status and things like that. One thing we did in this study, and I don't think I showed this in the earlier one, was something called the man drawing. And what we did is we gave them a drawing, as you see on the side, just a silhouette of a man. And we had them select different colored pencils that represent different parts of their identity, because we wanted to do something different to get at how do you integrate all the parts of who you are? How do you integrate your identity? Because again, if you think about it developmentally, that's a pretty cognitively difficult task. Even to ask, most adults, so how do you integrate your sexuality with your gender, with this or with that? So what we had them do is we had them select the colors and then color that in. And I'm just going to show you some of the drawings. I actually have a graduate student now who's analyzing this using some techniques from art therapy and some projective techniques using like the Rorschach and the TAT. So what we saw, and then they described these to us, and so we have really exciting narratives about how they talked about how did they integrate all these different parts of who they are into being a full human being. We're actually doing a study right now with HIV positive young gay men, and we're doing the same kind of drawings, and it's really pretty fascinating. I've just been out to San Francisco and Baltimore at weeks at a time collecting data, doing interviews nonstop, and it's been really interesting to see the way in which they're integrating the HIV into their identity. And so, hopefully before too long we'll be publishing something on this to use it both as a research tool, but also as a therapeutic tool. We have some people that are part of a research network that I'm part of that have been using this in a more therapeutic way as well. So some of the things that we've seen is that we've been looking at is the development of the multiple identities, as I've talked about. One project that I presented earlier today is by one of my former project directors was navigating and managing masculinity, which I'm going to go into a little more detail. Then the whole process of integrating ethnic identity and gay identity we've been looking at, the influence of natural mentors, and then the role of the internet. So just a couple of words about masculinity, because I want to be able to get to the last section, which is about some of our work in Kenya. We see that these messages are coming from a variety of sources, so family, peers, school, the media, and that the messages that young men are getting about their masculinity is really giving them pretty rigid norms about how they're supposed to think, act, and feel. And a lot of these don't fit in with how they currently think, act, and feel. And that we saw that there's a lot of intersection between race and ethnicity and class. So to be African American and to be a young gay man, you may get different messages than if you're European American and a young gay man. And then also a lot of these young men felt high degree of both explicit pressure and implicit pressure about acting in certain ways. So we heard horrific stories of young men who were beaten by parents for walking with a swish, or had one young man who the father was dunking him in cold ice water to get the faggot out, as he called it. So there was a lot of pressure, direct pressure, and even levels of abuse to try and get these young men to conform to what parents and others saw as a traditional view of how a man should act or behave. What we saw is that a lot of them talked about being able to balance both elements that are traditional feminine qualities and traditional masculine qualities. Not all of them did, though, but there was a real mix in terms of whether or not they did these and how they did those. So some of them avoided anti-gay violence through putting on a more masculine persona. In some of the neighborhoods, if you walk down the street and someone knows you're gay, you're going to get hit, you're going to get shot at, you're going to get beat. So some of them would butch it up when they were in certain neighborhoods, but when they were in others, they wouldn't. So for instance, earlier I talked about an area in Chicago called Boys Town, which is an LGBT kind of center of the city. So some of the guys, when they were in their, when they lived on the south side of Chicago, which is primarily African American and a lot of low-income communities, when they were over there, they would act one way, and then they would take the train over to Boys Town and then act a different way. And they even talked about that train ride from the south side to the north side being a transition from being straight to being gay. And a lot of them tied in masculine and femininity with sexuality. Even though gender identity and sexual orientation are very different topics, still, I think a lot of people tie in gender and identity and often aren't able to tease those two apart. I think a lot of times when we look at even youth who experience levels of abuse and harassment in school, it's not whether or not you're gay that matters, it's whether or not you act gay that matters. So kids who are abused in schools are those who act in gender atypical ways, regardless of their sexual orientation or their sexual activity. So we saw some of them would embrace both aspects of maleness and femaleness, and then some just kind of created their own sense of who they were. So a couple of the guys talked, I'm just being me, or I'm just doing me. I'm not doing male, I'm not doing female, I'm just doing me, and that's all I can do. This last one, navigating the current popular cultural consumption of the stereotypical gay male image. That sounds pretty geeky, doesn't it? What that means, basically, is what we saw some of the young men talk about is that because of an increase in some images in the media about gay men, that especially, it usually came back to Will and Grace, that some of their female friends wanted them to act in a certain way. So I remember one of the young men said, well, my friend wants me to be a Jack, but I'm more of a Will. And so I feel all this pressure. So I'm not getting pressure from my parents. They don't give a shit how I act. But it's my best friend who, she wants to be Grace and she wants me to be Jack. So there's all this kind of popular media consumption of what it means to be gay, and then some people are promoting those messages to the young people. So what impact does this have on HIV prevention? You may be saying there, okay, this is all very interesting. One thing that we've seen both in our data and other data is that sometimes when young men are struggling with their masculinity, that they may have an increased number of sexual partners because they're trying to prove their masculinity. If I keep having more sex partners, then I'm a man. That's the message. The more men you have sex, or more people you have sex with, the more of a man you are. Also having unprotected sex. We saw this a lot for our Latino young men, that to spread your seed to as many people as possible was a sign that you're a real man. If you can have more children out there, now a lot of them were having sex with men, but they were still spreading their seed. That's how a lot of them would talk about it. Also aggressive sexual activity. Some of the guys that were so tormented with this idea of having sex with a man and whether or not that meant that they were or weren't a man would have very rough and aggressive sex, which then, even if you're using a condom, it increases the likelihood of the condom slipping or tearing or breaking. And so that oftentimes, in combination with the unprotected, increases your risk for HIV infection because there's more tearing of the anal tissue and of the penile tissue. So that can lead to higher risk. And then also combining substance use and sex. So if you're struggling with the fact that you're gay or that you like to have sex with a guy, if you get blasted out of your mind on drugs or alcohol, you just blame it on that. So, oh, dude, I was so wasted. I didn't even know what I was doing. I don't even remember what I did. You know what you did. You remembered it. But you use that alcohol as a way to kind of excuse what you did. And then also minority stress and subsequent mental health. So people in different forms in psychological literature have talked about minority stress in terms of ethnic minorities. And some people are starting to look at this in terms of gay and lesbian individuals as well. And that's just the day-to-day stress of being gay and being oppressed. And that can have an impact on your psychological functioning, depression. And sometimes that then can also lead into increases in sexual risk. All right, so I'm going to click through some of this. So this is all of the things you should do, all right? You got that? So this is in working with gay youth. Some of the things that we found based on our data, really working on facilitating healthy identity development, positive connections community, positive adult connections, healthy family relationships, encouraging support from schools, working with ethnic minority individuals, realizing that you're going through an ethnic identity development process and a gay identity process, and then also the use of the internet. The internet is a mode through which people communicate, particularly if you're maybe in an area where you can't be open and go to a group and see other gay people, you can still connect with them through the internet. So there's a lot of opportunities for that. Just a warning, though, that there's real dangers out there. And so in working with young people, we need to be very clear and give them assistance on how to kind of surf the net and use the internet in a safe way for their prevention. The last project I want to talk about is about our work in Kenya. I've been doing work in Kenya since December of 2004. Some of the folks on our Chicago team, Thigio is a small rural community outside of Nairobi where we've been working, and that's the folks there. And then we have a team in Nairobi as well. We've developed an intervention called CHAT. It's communicating about HIV and AIDS together. This is a program initially developed for youth based in social cognitive theory, also the AIDS risk reduction model. We also used elements of empowerment theory because a lot of people in Kenya feel they have no voice because they don't have a voice, especially young people. There's even more marginalization of youth in a lot of Kenyan cultures than we see here in the U.S. I think young people in the U.S. think they have it bad here. When you go into other cultures, you see that there's an absolute silence around youth voices. So we worked on elements of empowerment theory. We also started working with individuals in the field of communication and bringing in transactional and intermediate models of communication, looking at both mass communication approaches and then interpersonal communication approaches. We did focus groups and other ethnographic work, and we also brought in Kenya national symbols, customs, and values. So this is our intervention that we've developed called CHAT. Just to show you kind of the stages of what we've done, collaborating and doing initial ethnographic work, a lot of time going through the community, going into people's homes, sitting and talking, working with youth, going to youth groups, a tremendous amount of work doing that. We developed the initial intervention. We incorporated the communication theory in practice. We started implementing the program and then looked at further enhancement. Then we expanded the program to meet the needs of other populations. So although we developed it initially for youth, we started getting calls from other folks that needed it for people who were living with HIV or for people who were young mothers. We also have been doing this in the prisons too. So we've done it in a women's prison and the men's prison. So we've had to do some adaptations. We also incorporated new modules on health and hygiene because especially if you look at issues around care of the genitals, a lot of times if you aren't taking proper care of the vagina and the penis, you're more likely to get infections, which are more likely to cause lesions, or microabrasions, which are more likely to increase HIV risk. Then we also developed incorporation of teaching techniques into the communication section, so this could not only be an intervention, but we also then started training other people in Kenya to be able to do this when we're not there. And future directions, who knows? We're continuing to expand it. We've been funded through the the feds for a while now, and we're looking at other sources of funding too to continue our efforts there. So one of the things that we included based on some of the cultural work and the ethnographic work that we did is we kept hearing from young people, we don't want to hear about HIV anymore because people think they know everything about it, but there's a lot of silence around HIV, even though people in the community are dying literally on a daily basis. So we really focus more on a health perspective. We focus on 4 aspects of health: spiritual health, social health, physical health, and emotional health. And what we did is incorporated on this side over here is the Kenyan flag. In the center of the Kenyan flag is a Maasai, which is one of the ethnic tribes there, shield. And so we talk about how that symbolizes protection. This is the coat of arms for Kenya, and you see the shield again. So the shield is a very common icon. It's a very common symbol that people know about. And there's a high degree of nationalism among youth. So we talk about the shield here of spiritual, physical, emotional, and social, and that's how we orient and begin the intervention. So it's all around health, promotion, protection from a Kenyan perspective. And that's one of our little kind of visual aids that we use. It's a really quick story that when we first did I wrote a grant and I went over with an undergrad and a grad student to deliver this intervention the first time. And we worked with a group of nuns actually to set up the sessions. And we were told before that there'd be like 30 to 45 young people in the group, and we'd do maybe a group a day for a week. So we thought, okay, we can handle that. So we get there the night before the first session, and I went to the one sister, Sister Eileen, and I said, okay, Sister Eileen, I just want to make sure now, how many people do we have tomorrow? She said, well, probably about 300. And we're like, oh, shit. We were going from 35 to 300. So we had created these nice little handouts and little, kind of little booklets and all this other kind of stuff. Well, we had to throw all that out the door. So we were up literally all night taking everything on the handouts and putting it on that big poster paper. And that's some of my beautiful artwork. It's a good thing I had some, artistic background. And so that's how we do it now, is we use a lot of these poster papers because our audience is sometimes when we're in the prison, we do groups of 200 people at a time. And so you can't, and 2 in a prison, we can't give them handouts. So we have to do whatever it is that we can work with. The interpersonal communication has been very inspirational and very interesting to use. One thing that we found is that people don't always have shared understanding. Just like the initial activity where you didn't all see the same thing, when people talk about HIV, because people don't talk explicitly about it, there's a lot of assumptions made. And so we really have worked on trying to help increase effective communication, something called closing the communication gap, giving clear information, active listening, the listening process, nonverbal. So we have part of our intervention is just focused on communication. We're not talking about routes of transmission at that point. We're not talking about the traditional things. We're talking about how do you talk and communicate with another person. This is one of the graphics that we actually developed with young people there. They're having a really hard time understanding the concept of viral transmission, about one person having HIV and passing it to another.